how B-mode ultrasound works. Basic types of ultrasound, if we want to go a little more into detail now. A mode, this is often used in ophthalmology, and this gives you just one dimension. It's not used often in neurosurgery, so we'll skip through that pretty quickly, but it's just good to understand. You get a waveform with spikes and peaks at the interface between two different tissue densities. So it's often used in the orbit to understand measurements that are normal or abnormal depending on various technologies in the eye. B-mode ultrasound, as it was developed, is really what led to a lot more utility in other realms of medicine, including neurosurgery. It's called brightness modulation, and this is a two-dimensional image of the underlying tissue. And again, the brighter the image, the and focus the out. If we go to C mode, this uses data and range of depth from the A mode and transitions to B mode to examine the whole region at a depth originally employed in the 2D imagery. Also, it's used more in cardiac surgery. Same with M mode, which gives a time factor. And Doppler comes back to being relevant to neurosurgery. So this looks at blood vessels and flow, including flow velocities. Color Doppler adds directional information to blood flow imaging, and power Doppler, you lose directional flow information, but you can image smaller vessels and talk about it a little bit, but you need parallel the blood vessel you're trying to image to get accurate velocity information, and power Doppler, you don't have to do this. So there's settings where it's useful to use one or the other. So if we want to talk about the history of ultrasound use in neurosurgery, it actually goes back to Colorado. So the first B mode ultrasound, it was actually A mode, but the first ultrasound use in neurosurgery was at the Harvey Cushing Society meeting which happened in Colorado Springs, April 17th, 1950. This was a research study, and they used what was then a US military device from the Navy, an ultrasonic trainer device. It was called the 15ZI, and it was developed by the Special Devices Center. It was mounted on a cylindrical chamber, and it resonated at 15 megacycles per second, and then went through water that was in the chamber to essentially a rubber condom that it was on the end, and then they tried to see if they could these through tissues and whether they could tell if there was tumor inside brains or not. And this is a diagram of that. Oh, yes, happy to do this. All right, so it couldn't send and receive at the same time. It was a very simple device. It would send and then it would pause to then receive. And then they recorded it on a synchroscope and then photographed it to obtain permanent records. And first they looked at normal versus neoplastic tissue that had been removed surgically from the brain of patients and field, because there's some question as to the safety of using this in a living patient. And then after autopsy, when patients had died, they used it in normal patients or patients that they presumed had tumors, and saw how predictive it was. And because the concern was that tissue damage could occur at least at certain frequencies of ultrasound, they then used the same frequency of ultrasound in the open exposed brains of a number of animals. They then ran this ultrasound for 20 minutes just to prove that it was showing no damage to the brain. And certainly now we know that ultrasound can be used. So this was relevant to their study. But what you can see here is normal brain tissue. form. As you get, so A is normal and is tumor tissue, and you see that the tumor tissue being much more dense, you have much higher weight and clearly distinguishable, demonstrated on the left in panel A. So that was the first demonstration of, thank you. That was the first demonstration in humans of the potential for ultrasound in neurosurgery. First use of B-mode ultrasound where you could actually see an image was in 1978. It was for a spinal cord tumor. And brain and spinal cord parenchyma have viscoelastic features that permit exceptional ultrasound propagation. It's when you're open at surgery, you have attention of the ultrasound beam by skin or connective tissue or bone. And it's real-time information, so you get a superb temporal and spatial resolution. In this study, we're going to go through this relatively quickly, but there's a 50-year-old man, and he presented with numbness in the right arm and fingers and difficulty walking for a year. They presumed it was something in the cervical spine. This was pre-CT, or I mean pre-MR. CT was normal. CT myelography showed an expanded cervical cord. At surgery, an ultrasound exam suggested there was a cystic lesion inside the cord at the area of widening. And this was between the lamina, so this was done before surgery. They thought they could appreciate the cystic mass. They went to surgery and did a laminectomy and intradurally tried to get a biopsy. And pictures weren't very good back then. They're much better now, but you can see there is a change in density inside the spinal cord here, which was consistent with a cystic spinal cord tumor, and the spinal cord is expanded in this portion of the cervical cord. So this is just for your reference. It's important to recognize what's brighter or darker on ultrasound imaging in the brain, where water is going to be very dark. Cysts will also be black. Subcortical tissue tends to be quite dark unless it's edematous. And then, so white matter is darker because of its fat content than gray matter. And then that's, as you move toward the left, cortical tissue is then brighter. Tumors are usually on the spectrum between cortical tissue and meninges. Meninges are quite bright. And then certainly acute blood is bright, whereas subacute to chronic blood becomes darker. Neurosis can be quite variable, and brain contusion is quite bright as well. And then calcification shows up as bright. And how you can tell something's calcified, you also get a shadow behind the calcified object. So this is another view of that spectrum, looking at specific tumors of various tumor pathologies in the brain, and darker lesions being toward the right, brighter lesions toward the left. The benefit of a graph like this is, as you're new with ultrasound, the lesions on the left that are brighter and more distinct from the brain are going to be easier to recognize on ultrasound. And the further to the right you go, the harder it is and the more experience you need to distinguish tumor from surrounding brain. If we think of point-of-care ultrasound in the ICU, we can do ultrasound-guided procedures for central lines, IVs, femoral blocks, and other paraspinal blocks. Ultrasound can be used to guide lumbar puncture in settings where the patient just is difficult to get into the intrathecal compartment. Let's talk some about limitations of ultrasound. So I think the first one is many providers have limited or no experience in brain and spine ultrasound imaging and what topographic anatomy looks like, what artifacts look like at surgery, and how things change on ultrasound over the course of an operation. So then you can confuse, remember contusions change, right? Imaging, hemostatic agents, cotinoids, Surgicel, right, can change what things look like on ultrasound, and that can be difficult for interpretation. We find for most people it takes about 40 to 50 cases for you to be really comfortable with the use of ultrasound. So don't give up too quickly. Bring it in, look at it, use what you can, and what you can't understand, just move on and operate as you normally would. And there's a learning curve that after you get, like I said, about 40 to 50 cases under your belt, usually you get much better. And if you start with those easier lesions that are on the left side of that graph that we showed before, and then kind of move forward to other lesions, it gets easier. And so what I recommend for people is if you have a radiologist who deals with pediatric patients with head ultrasound, having them come to the OR with you to help with interpretation early on, that's very beneficial. If that's not available, then just we'll talk about some hints as to how to help you through that learning curve. But the key is to just bring it into every case, to practice, and you'll get better. So the second point is you should, most neurosurgeons are familiar with MRI and CT, where we get orthogonal planes. We look at axial, sagittal, and coronal views. You can get, on an operative case, you get 2 orthogonal views with each exposure. It can be different. In the spine, it's axial and sagittal. On a terional, it's an axial and a coronal. But you can also get oblique views. Oblique views can be quite confusing, so it's important when you first start, look at an orthogonal view. And if you have a coronal option, that's often super helpful to start with a coronal view. So on a terional craniotomy, start with a coronal view, okay? Well, ultrasound, we've already talked about that, so we'll move on. It's demanding because you board with 100 different buttons, and that can be intimidating, but it really comes down to just a few key things that need to be adjusted. And there are some automatic settings. If you set it to abdomen, for example, so the abdomen is similar to the brain in terms of settings that you want on the ultrasound machine. So if you start with abdomen, then a lot of those things are adjusted, and then you only need to make 2 or 3 different adjustments in terms of zoom, gain, and frequency are really the only 3 that you need to mess with after setting it to abdomen, at least in the beginning, okay? Ultrasound is considered an operator-dependent technique. There's a steep learning curve, so it does take time and experience. Image quality is affected by small acoustic windows, air, table positioning, right? Because you need to have your surgical plane horizontal to the ground so you can fill the cavity with irrigation, because ultrasound won't propagate through the air. Hemostatic material blocks the signal as well. Edema changes what the brain looks like. If they've had prior radiation, there's going to be gliosis. That can make problems as well. Lesions such as microabscesses, diffuse white matter injury, and encephalitis are not well visualized by ultrasound, but some things like microcalcification are actually better visualized on ultrasound than they are on MR or CT. So if we talk about positioning for the ultrasound, you need enough space so that the ultrasound device can be next to you at the operating table. Touchscreen monitor and keyboard either needs to have a sterile drape over it or have someone who knows how to use it next to it controlling the buttons. The patient should be positioned again for a horizontal surgical field. Exposure has to be large enough to house the probe, so it depends on the size of your probe, how large a craniotomy you need to make, and you should be able to freely tilt it and orient it as you need to. B mode, you begin with visualizing the entire lesion, and you want to understand its relationships with healthy neurovascular structures and brain parenchyma. You want to start with a wide field of view. Check your normal anatomy, where it is in relationship to that normal anatomy, and then zoom in on the target, increase the frequency of the probe to improve the resolution. And that's kind of a key point, so I'll bring it up here. So if we think of frequency in general terms, The lower the frequency, the deeper you can see into the tissue. High frequency probes cannot see as deep into tissue, but they give you better resolution because you have a smaller wavelength, okay? Bigger wavelength goes deeper, penetrates deeper, but you can't see as high of resolution. So you start with a low frequency and look at the whole field, and then you zoom in, increase the frequency to examine the lesion in better detail at higher resolution. And the three things to focus on: frequency, power, and focus. And if you have different presets, we've talked about that. Abdominal preset seems to be, it starts at a really low frequency, which is fine, but just kind of be aware of that. But at least the gain parameters tend to be similar. So here are some examples. This is a coronal view of a brain tumor, relatively superficial. You can see that it has a cystic component as well as a nodular component, and then there's edema surrounding it. So you can see this is the normal white matter, and this is the edema, a little brighter, and then the wall is quite echogenic, which is common because you have, wherever you have a sudden change in tissue density is where you're going to get a lot of reflection, which then becomes a bright signal, okay? This is our OR setup in Colorado. There are 4 specific neurosurgical probes, but really any probe can work. Just what's the difference with a neurosurgical probe? They're smaller because our craniotomies are smaller than, say, an abdomen. Methodology should be standardized, so I recommend you kind of have a sequence that you go through and you do it the same every time, especially if it's new for you, so you don't lose track of what you're doing. You begin with an orthogonal scan, which we talked about. So if we start with terional, you're going to do an axial and a coronal view first. Then you do the probe tilting and shifting to see the whole lesion, right? With the oblique views, just to get a better understanding of everything around it. I start with B mode, and then in all those 3 modes, and then I go to Doppler to look at the vasculature, and I do it the same way every time, right? And then you want to scan. I usually scan before dural opening, ensure, especially navigation, to help ensure that your exposure is adequate. Then you open dura and look again, because you'll get attenuation through the dura. That's nice to be right on the surface of the brain with the probe to see the tumor better. And then I get a few scans during the resection if I'm doing a tumor or hematoma evacuation or an abscess, let's say, drainage, and then a scan at the end, post-dural closure, to get a nice control ultrasound to make sure you don't have any post-operative complications like a large hematoma in the cavity. So I've just said all these things basically just to save us some trouble. Vascular imaging, we talked about the Doppler effect. The wave is proportional to the velocity of the blood. The direction of the vessel if you are trying to get continuous wave. Doppler to get accurate velocity information. And on color Doppler, it's color red typically is towards you, blue is away from you. It's not artery versus vein. To know that, you have to look at the waveform of the vessel to see if it's arterial or venous in terms of the waveform and the velocity. But I won't dwell on this too long because Dr. Kava is going to talk more about vascular imaging. But you can see that when you turn Doppler on, this is a tumor. And Doppler here is very useful to see the vascularity of the tumor. You see where its originating vessels are in this sequence. That can guide resection and where you need to get hemostasis to reduce bleeding. People also use these for AVMs to identify draining veins, supplying arteries. In this case, this is a meningioma parafalcine, and this is a patent superior sagittal sinus. So you can use this to ensure that you maintain patency of the superior sagittal sinus, or you can evaluate if it's patent at all. on periphalcine meningiomas to guide resection. This is just an example of an infant Doppler study on ultrasound, and you can see the vertical lenticular striate arteries, but don't think that you can't see them in adults as well. Once you learn Doppler well, you can see the lenticular striates quite well. This is power Doppler, so that the color Doppler, you can't always see them, but power Doppler, you can typically see the lenticular striates, which helps prevent injury to the internal capsule and hemiparesis, especially if you're in the insula. Color, again, you get directional information, power Doppler, you lose directional information, but you can then image smaller vessels, and you don't have that incident angle problem for velocity information. Spectral gives you flow velocity information. I'll give a case illustration. This is a 66-year-old woman, had an expressive aphasia, mild right upper extremity weakness, and she had this lesion on MRI, which was non-enhancing and cystic. And what you can see on the ultrasound image on the left, this is also a coronal view, but it's tipped on its side. So you see here, here's the interhemispheric fissure. These are the two lateral ventricles. And this is the lesion, which is on the left side. And here you can clearly see the capsule of the tumor. So ultrasound was very useful here, and that the capsule of the tumor was actually better visualized on ultrasound than it was on MRI, because there had been a little prior bleeding, and the MRI showed some of the hemosiderin and didn't clearly depict the capsule exactly well. But here is post-resection now. This is now flipped the other direction, but you can again appreciate that compressed lateral ventricle has now been nicely decompressed by resection of the tumor. And this is one of the artifacts that we'll get into, but if you image through fluid, the back wall, because you have less attenuation through the fluid, it's going to reflect brighter than it will over here. So the base of that fluid cavity is always going to be bright. This is a little contused brain, which is also bright. So looking multiple times over the course of an operation will help you not mistake that with residual tumor, okay? And this is just the postoperative scan showing some hemostatic material in the cavity, but the tumor is completely excised. This just to show how bad some artifact can be. This is a piece of gel foam stuck in the cavity, and you can see nothing behind the gel foam. Right, that can be bad in some settings, but also can be helpful. So if you take a very small piece, like a couple millimeter size piece of gel foam, that can be a marker to help you know where you are. So if you're under the microscope at the depth of the cavity, and the brain folds down on itself when you put the ultrasound in, and you don't know quite where you are anymore, putting a little marker with gel foam now that's not big like this to block the whole signal can just be a bright spot that you see to guide where you are on the screen. This is a cottonoid, so you can see there is some attenuation. So you see you have that artifact of it being bright on either side here past the fluid, but this blocks signal, so it's darker here. Okay, so just be aware there is a signal attenuation from anything that you put in the cavity. And if you have fluid in the cavity, that allows you to use the ultrasound, so that's important, but it's going to be brighter at the back wall of that fluid cavity, so don't confuse that for tumor. So this shows it in the spine, where on the sagittal view, right, we see very nicely, right, the different layers as you go down through the intrathecal compartment, and you can see the dura. In this case, there was an arachnoid cyst here that's blocking the free flow of CSF. We'll skip some of these, but in conclusion, ultrasound has a long history in neurosurgery. Recent improvements in technology have increased the benefit and the utility of ultrasound in neurosurgery for diagnosis and treatment. And although there's a steep learning curve, mentored learning and frequent practice can flatten the learning curve and increase confidence in ultrasound image interpretation. Thank you very much. And I think I'm giving the next lecture as well. No. Yes. Okay, that's fine. So this will be a quick presentation. We'll spend more time on adult ultrasound, but it can be useful to get online images or a textbook of pediatric or neonatal ultrasound of the head, just because we've been doing this longer than, and radiologists have been doing this because of the fontanelles being open to get good ultrasound images of the brain for a very long period of time, for decades. So while it's not exactly the same as an adult patient at surgery with pathology, it can be useful to understand what's going on. So if we think of the anterior fontanelle, you're going to have two images. You're going to have a sagittal or a coronal view, and there's a direct coronal, but then if you want to see the whole brain, because you just have one little window to look through, what they do when sonographers look at infant brains, they have very specific views they look at. It's easier to show here, where first you go through the frontal lobe down to the orbital roof, then you come back through the lateral ventricles at the anterior commissure, at the optic chiasm, then back at the anterior commissure, and then back to see the brainstem and the cerebellum, and then finally get a posterior one, the entire neonatal brain. And on the coronal view, you get 5 images. This just shows one side, but there's 2 others on the contralateral side that are picked up. And this has all been standardized. Transducer obtains an image through the frontal lobes. We've talked about this. This is what this looks like. And you can see this is quite different. So I'm not going to belabor this too much, but just understanding that as myelin forms, right, the older the brain, the more distinct it's going to look. Here you get the interhemispheric fissure. This is still not as well myelinated as it gets later in life, but as you come back, you can see this is through the skin. So the brain images are much more distinct, and we'll show some of those later. But now we get back into the third ventricle. So you see these are all oblique views. They've been standardized in pediatrics, but they're not standard if you have CT or MRI. But you can see a lot of things, and that's where this is valuable, right? So CSF of the body, the lateral ventricle, is going to be quite dark. The basal ganglia are going to be brighter because they're gray matter, and meninges are going to be quite bright. So you have interhemispheric fissure, and then if you get back, so this is medulla here, and what you're seeing there is the choroid plexus going out, foramen of Luschka, which is why it's bright. Otherwise, the brainstem is quite dark because it has such a concentration of white matter. If we go back even further, you just see some of the same things where you see the trigonal lateral ventricle. Matter can form a blush here. This is then third ventricle, and up here is parietal cortex. So it's a little difficult if you haven't looked at these often to understand what's going on. But I think it's good for you just to at least get some idea of what you see, what you're looking for, and what normal anatomy can look like. This is then the sagittal view, and you can see a lot of anatomy here, where we have the palm, fourth ventricle, cerebellum is back here, and then. But you can certainly appreciate the corpus callosum, the cingulate gyrus, the lateral ventricle, the thalamus on our midline sagittal image. So I'm going to end the lecture here and move on to the third one, which is looking at pathology in the brain. So brain tumors, ultrasound can be used at each step of the procedure. We've talked about this already, so I won't belabor this point. Now, if you use this is showing a phased array probe. So there's 4 different kinds of probes, 3 basic ones really. We think of linear probes where everything goes in a straight line, gives you higher resolution. More sound waves are traveling in a straight line. Convex probes, or curvilinear they're called. So those, you have a little lower resolution, but a wider field of view, right? And then you have a phased array, which starts flat, but it sends signals out diagonally as well. So classic for this is a cardiac probe. To see around the ribs, you want to see wider than just between the rib space. So even though it starts flat, it sends some signals out laterally. So that does hurt the resolution of the probe, but allows you to get a wider field of view. Now this shows a lesion that we missed, right? We see just the edge of it here, but the phased array probe allows us to see past the bone edge. To notice deeper lesions obviously are going to be easier to see. It can be coupled with MRI, and this, and even overlaid on navigation systems to help adjust for brain shift, which is kind of the bane of navigation systems. Is you have a preoperative CT or MRI, and then now you've done an operation, and in that operation, now the brain shifts, so none of it's accurate anymore. Really, as soon as you start resection, well, ultrasound doesn't have that problem because craniotomy, and after the craniotomy is done, I rely essentially only on ultrasound at that point. These are the different transducers that we talked about. The phased array probe, which in neurosurgery would be a Babel probe. The phased array probe, which is the cavity in the center, convex, and then some people use 3D probes. That gets more complicated and isn't yet as relevant to neurosurgery. This is a metastatic tumor, and here you can see this is a coronal view, right? Here's the tumor, has a necrotic center, solid capsule, and this is then edema surrounding the so this is the tumor itself, this is edema, and then this is normal white matter beyond it. After resection, you can see this is right at the tentorium, right? And this is the interhemispheric fissure. And here you can see the folia very nicely of the cerebellum, which was attenuated before, but now that we just have more, now we can see the cerebellum really well. Don't let that fool you. We didn't leave tumor behind. We just have, through that fluid cavity, a very bright meninges and tissue beyond. All right, this is that edema that we saw at the beginning, which we know is not the tumor, right? And up to the right just shows the preoperative and postoperative scan showing gross total resection. Echogenicity of an intracranial tumor is dependent on cell density, right? So higher density equals greater echogenicity. In low-grade gliomas, that's probably the hardest to distinguish from surrounding brain, especially if it's a diffuse glioma. If it's, say, a pilocytic astrocytoma, they can be pretty dense with fibrous tissue, and they can be quite bright. But low-grade diffuse gliomas can be quite challenging, and the border of the lesion can be difficult to detect, and especially if you use a sector, which it means that phased array probe we talked about, or a curved transducer. So it works better to use a linear probe if you're doing a darker lesion and a higher frequency to get better resolution. Okay. Contrast between tumor and tumor-free tissue should be optimized before dural opening, so make sure you kind of manipulate most of your settings before you get in to the lesion and start creating artifact by creating contusion in the brain tissue so that you know your image is as good as it can get. So all those little adjustments we make on the machine. Based on imaging settings, depth of the lesion, contrast, focus, other imaging settings can be optimized before artifacts will obscure visualization, so that we talked about. And contrast between normal brain and tumor is higher using a linear array transducer at higher frequencies. Okay? And we've shown that image. This is just another picture of a number of lesions and what you see on CT or MR and what you see on ultrasound. Okay, so ultrasound works very well, and you can see a lot of the anatomy, its relationship to surrounding structures. Here's that graph again, just emphasizing, you know, the easier things to remove, or sorry, the easier things to visualize are toward the left. The harder things to visualize and distinguish from normal brain tissue, edema, gliosis, etc., to the right. This is an example. So this is a high-frequency linear array that has a little virtual sector array portion of it, where you can see a little wider than the probe itself. But you can look at the resolution that you get here, distinguishing different densities of the tumor and tumor tissue versus surrounding brain. And this is a high-grade glioma, areas of central necrosis, some very fibrous areas here, and then it fades into the normal brain, as you'd expect from a high-grade glioma. This is a low-grade glioma, just showing that if you use high-frequency linear array probe, you can actually distinguish low-grade gliomas quite well from surrounding brain. Correlates very well to the T2 flare MR, which is displayed there on the left. This shows acute hemorrhage. This is a pediatric ultrasound showing intraventricular hemorrhage. And again, acute hemorrhage is bright, quite echogenic. As it becomes more subacute to chronic, it gets darker. Here you can see a fluid level, so this is acute but not completely clotted, or there's a layer of CSF above it. But at any rate, there's a fluid level, so you can appreciate that just like on CT or MR. Form intracranial ultrasound, good knowledge of what's typical for artifacts is crucial in order to interpret imaging results properly. Type and extent of artifacts change from type of transducer that you use and based on tissue assessed. You can get reverberation artifacts, which are just kind of multiple reflections of ultrasound waves that either give you a mirrored image or multiple mirrored objects. It's not terribly common in cranial surgery unless you have like a tool, like a metal tool in the field while you're doing ultrasound. Of course, that can be very useful if you want to guide something in, like a ventricular catheter, into a ventricle. I find it if you suddenly see the brain swelling around you at surgery and you don't know quite what's going on, ultrasound's very helpful. You pull it right over, you look, you can see a big hematoma if there's a hemorrhage, you can see hydrocephalus developing, right? And then you can even pass a catheter into the ventricle of the brain to be able to drain that ventricle if necessary. Especially because at surgery, you're often in kind of a strange position to use anatomy to find your ventricle. So instead, you can see it on ultrasound. And we talked, some of you were, at least Dr. Blessing was with us in Moy, where last week we had a conversation about in-plane guidance with the ultrasound, and we can maybe demonstrate that today, how you can actually follow the EVD catheter all the way down to the ventricle on ultrasound under direct image guidance live. So you can get distortions, phase range artifacts. They're also not common in neurosurgery, but I think the most common distortion is that the speed of sound in water is high and there's very little attenuation, so you get that brighter back field when you have a fluid-filled cavity. But you need a fluid-filled cavity to be able to see all your structures because ultrasound won't go through air, right? So if you have different tissue densities, then you can lose signal behind those. Attenuation of brain tissue is relatively high, and but the good news is it's relatively homogeneous even when you have a tumor with regard to attenuation. And hope we don't lose our screen with the wind. And water has very little attenuation, so it can be really helpful. Sometimes you want that, but sometimes you want to see without that water artifact. So even if you have a fluid-filled cavity, if you're concerned that the base, you're like, is that tumor residual or is that artifact? You can actually put the ultrasound on the brain instead of right over the fluid-filled cavity and look over at that same tissue. And if you're only going through brain to it, now see how does that base of the to before, and does it look the same as surrounding white matter? That can help you distinguish that artifact. So here's some examples. So this is a reverberation artifact. So often if your probe's at the edge of the bone, you'll get these stripes that occur because bone attenuates most signal, and you'll get a reverberation artifact behind the bone, or sometimes complete dropout of signal. Here we showed what happens at the back of a fluid-filled cavity where everything gets brighter. This is an abscess. Just to show you an example, so you see the wall of the abscess and the center of purulence or necrosis. So that shows up quite well. This is a little depiction of what I was talking about. So if you want to see, is this residual tumor, it'll look bright if you put the probe here. Is it still bright when you look through brain tissue only, or does it look the same as all the surrounding white matter? If it looks the same, you know that was just artifactual. Vascular imaging, we're going to skip since Dr. Kava is going to get into that. We've shown some of these pictures already and some of the artifacts. This is another patient who presented with dizziness after a fall, had a history of non-small cell lung cancer, and had left upper extremity weakness on exam. And he had this prefrontal lesion in the supplementary motor area that was quite superficial. But here again, you see a very clear capsule of the tumor, cystic component to the tumor, which is common in adenocarcinoma of the lung. And then it can be edema can be variable. Sometimes it's darker than normal white matter. Sometimes it's brighter. Part of that depends on your machine and the imaging settings on the machine, and so the literature is a little contradictory. I would say from my experience, it's more commonly brighter than normal white matter. This is another picture of that same patient. This is now after resections. We have a little bit of cytotoxic edema around the margin of resection. How you know that that's not tumor is because in your mind you've either taken pictures of the screen to then refer back to, right? So you freeze and save those images so you can look back, and remind yourself, and you've looked frequently multiple times with the ultrasound over the course of the procedure, so you'll watch that part of the brain change over time, so you know it's cytotoxic edema and not residual tumor. Okay, this is another brain abscess case, and this is a Chiari case, so Chiari decompression. You can appreciate the cerebellar tonsils here, and upper cervical syrinx. This is the brainstem and the spinal, and this is the dura. So this is before, so you take the bone off and you look, and you can see, am I already partially decompressed? Have I adequate, do I need to open C1, let's say? You can see where the base of the tonsils are. I like on a Chiari to open so that the bony opening is past the cerebellar tonsils to make sure you get adequate decompression. Ultrasound helps you see that, and you can also watch the pulsatility of the foramen magnum, and you can actually physically watch the tonsils right up after you do your duroplasty, and you can watch the pulsations and know that CSF is well around the cord and brainstem to make sure you did an adequate duroplasty. Some dural substitutes block signal quite a bit, but pericranium ultrasound sees through very nicely. So shunting, I don't think this is going to work on a transferred image, so I can't show you the video, but you can follow the ventricular catheter all the way in under direct visualization in real time, which is what this would have depicted. After you remove that metal stylet, you can see the catheter through brain parenchyma. You can also see the tip of the catheter because the side holes reverberate nicely through the ventricle, through the CSF of the ventricle. It tends to be hard to see. Although the metal artifact you could see very well with the stylet when it went in, but this just is meant to show you that if you have a small probe, like a burr hole probe, you can easily access the ventricles, but at surgery, if you have hydrocephalus because you've obstructed and you have a lot of brain herniation, this can help nicely guide you in to drain the ventricle, especially if you're in a non-anatomic position. Oh, it's working. So that was an example of a live image, right, of the catheter going into the CSF space. In summary, the key to successful intraoperative ultrasound involves learning the use of the machine, especially learning those three tools: frequency, focus, understand basic ultrasound anatomy of the brain, using standardized approaches, orthogonal views, right? Ensure an improved understanding of what's being visualized, understand how pathology affects the echogenicity of various structures, learn how common artifacts lead to misinterpretation of imaging characteristics throughout the resection, and the best way to learn that is image frequently during a procedure, right? And if you do that every time, then you'll get better at recognizing artifacts. With practice, ultrasound can greatly enhance cranial surgery, lesion localization, catheter placement, abscess aspiration, needle biopsies, etc., and can be useful in the brain, spine, or for peripheral nerve surgery. Thank you very much. So I think with that, I'll open to questions, and then we'll give Dr. Kava some time. Oh, at the very end? So at the very end. So Dr. Kava, I think I'll pass it.
Yes, I would request again, Dr. Sembata. Please, let's give Dr. Ryan the round of applause. There's no wasting time here. He couldn't wait for his salutation. Can you come and give his salutation before his presentation so that they know who is presenting to them? Thank you.
Good afternoon once again. Dr. Kava, we are so much privileged to have you here. And we have been privileged to have some sessions, online sessions sessions with Dr. Carver on a number of aspects of neurosurgical topics. So Dr. Carver Lewis is an associate professor of neurosurgery in the University of Colorado. He's also a neurological critical care fellow and instructor in the Department of Neurosurgery. Once again, Dr. Carver, you're most welcome. Thank you.
Thank you, Joseph, for the warm welcome. Let me find my presentation. See if Well, before we start, I wanted to thank everybody for coming. The relationship that we have forged with MRRH and Neurosurgery has been getting stronger, over the last year or so. I see Joseph, I see Noah, Dr. Blessing, Professor Kitcha. Where is Beatrice? Is she around? Oh, there she is. She has been instrumental in developing the program. As you guys know, we meet each other twice a month, discussing cases, the residents presenting cases, some of the faculty from here as well. So I'm very happy to be here in person, and I hope that the relationship will continue and only get stronger in years coming. So let's talk a little bit about the intracranial vascular anatomy with ultrasound that I find really useful. The main modality that we use in the ICU and our institution is transcranial Dopplers, and we use it mostly for the determination of cerebrospinal. Looking at your machine last year, I saw that there is a setting for TCDs, so depending on how many hertz can we actually use, maybe we can do a demonstration when we are in the hospital. So this is what the ultrasound with transcranial Dopplers look like, and describing the intracranial vasculature. You can see the circle of Willis. You can see both MCAs, you can see the ACAs, the ICAs entering the skull as well. This is in a easy to do ultrasound in a pediatric patient, neonate. Remember that to access the intracranial vasculature with ultrasound, you have to have a window. You have to have something that will allow the ultrasound waveforms to penetrate inside. When Dr. Ormond is in the OR doing it, he has the bone off, so it's easier to do the ultrasound that way. When we don't, we have to rely on the fontanelle, right? Or if the patient has a decompressive hemicraniectomy, it's another way, to access. Or using some windows that in the parts of our skulls that are, thinner, allowing a low waveform, 2 hertz or so, to penetrate through the bone. Usually it's the squamous portion of the temporal bone. You can show some pictures as well. You can use other windows as well. This is another pediatric patient as well, in which you can identify vascular structures. You can see, for example, the vein of Galen right there. You can also see the pericallosal artery right there. So it's a very well, it's a very useful way of doing it. And like Dr. Orman was saying, it's also that you can also perform at bedside, right? Instead of having a very sick baby or not the ACAs, the PCAs, and the vascular arteries. Sometimes we can access the terminal portions of the vertebral arteries as well. And all of that comes to the fact that when we use TCDs, we're trying to determine if there is adequate blood flow through the blood vessels. And for that, just a brief reminder of cerebral autoregulation. So that's something important to take into account, because if it is intact, the cerebral perfusion pressure is going to remain in a particular range, like here, no matter what your maps are. But if you have sustained an injury, you have sustained a TBI, for example, that ability to constrict and dilate is gone. Hence, your ICP, your cerebral blood flow, is going to be linear in comparison to your map. So that's a way that you can actually, approximate in the clinical, setting with your patients. If they have a TBI, they have a trauma, or they have any other intracranial abnormality, then assume, which is a safe bet, that the cerebral autoregulation has been affected and the relationship this time is linear. Another thing to take into account when we use transcranial Dopplers is that what we're basically measuring is velocities. Just imagine a pipe, right? Fluid, water is going through the pipe. The smaller the pipe gets, the higher the velocity is, right? But there is going to be a point at which the pipe is going to be so collapsed that there is no flow going to go through it. So as you can see, this is the Spencer curve, in which as the diameter of the blood vessel is being affected, as you can see, the velocities are going up. And at some point, the velocities just drop, meaning that there is no more flow going through that blood vessel. That's, for example, in cerebrovascular arrest and brain death. So something that even though we are not actually measuring directly the blood flow, the velocities give us a good approximation of what's going on with the cerebral blood flow in our patients. We talk about windows at the beginning, the different windows that we can use to access the intracranial vault in somebody who does not have a decompressive craniectomy, for example, or doesn't have a fontanella, like in the adult population. The temporal window is particularly the most commonly used. You can also go through the eye, because there is direct access there into the sinus region. And this is just a little example of what the blood vessels look like, and the comparison that I was telling you between high resistance and low resistance. You can see at the level of the aorta, using the same probe that we use for transcranial Dopplers, you're going to see high resistance pattern. There is not much diastolic flow. A little bit better in the CCA. Look at the ICA. The ICA in the extracranial portion is already developing a diastolic waveform. And the MCA has a systolic waveform, systolic peak, and a diastolic plateau. So that basically is telling you that that brain is perfusing during the diastole, and depending on the velocities and the direction of the flow as well, you can make your clinical determinations following that. Other windows that can potentially be used, besides the transtemporal and transorbital, the submandibular, that we don't use very often. The majority of patients are have C-collars, or they have spinal instability, or high ICPs, so manipulating the jugular area right there is a little bit tricky. And obviously we cannot turn them around and put them, tilt the heads too much to actually get a transforaminal window. However, depending on the depth, right, and we'll talk about that in a second, we can access even the basilar artery from the transtemporal window as well. So this is just to what I was talking about the temporal window that gives you basically an axial plane and a mesencephalic view of the intracranial vasculature, and it allows you to identify almost the whole circle of Willis using transcranial Dopplers. Others that I mentioned, the occipital, orbital, and submandibular. At our institution, the ones that we use the most are the transtemporal and the orbital window as well. Now, you're going to ask me, so how are you going to reach, all the way down? Well, each particular vessel is going to be on a particular depth in relationship to your probe, right? In the case of a of the temporal window by the depth of 55 millimeters, you are basically confident that when you find an artery, that artery was going to be the MCA. Okay? And basically, it's going to give you some information that looks like this. You see, this is a typical waveform that follows a cardiac cycle with a systolic peak and the diastolic plateau or notch right there. This is what your artery should look like. This is another example, and that's basically going to tell you the direction of the flow. I don't know if the ultrasound machine here, it depends a lot of software also. I don't know if we'll be able to have the software, but we can work on achieving that, as our relationship continues going through. So basically above that line means that the flow is coming towards you. And if the waveforms were in the bottom, this basically means that the flow is going away from you. For example, if I'm insonating the right MCA from the right, through the temporal window, and it gives me this picture, basically the flow is coming towards me. If I was down, I will say, okay, that may be the bifurcation of the ICA, or maybe the ACA going, away from me. And if I'm really deep, let's say, 7 centimeters or so, then that may be the contralateral MCA as well. It has a lot to do with what Dr. Ormond explained already about the physics of ultrasound. Here to exemplify, the depths of each particular blood vessel from a temporal window. The MCA, like I say, is going to be at 4.5 to 5.5. The bifurcation a little bit deeper. The ACA up to 8 centimeters. If you want to reach the PCAs, 6.5 centimeters, and the basilar will be a little bit further away from that. But at the same time, remember, also considering the direction of the flow. If the flow is coming positive or negative. If it's positive, it's coming towards you. If it's negative, it's going away. Hence, that allows you to identify the vessel in a more accurate fashion. We talk about this, the majority of the things that we use is the mean flow velocity, as well as the peak systolic velocities. There are different parameters for identify, for example, stenosis, or identify cerebral vasospasm as well. The pulsatility index, and this is something that the machine gives you, the information the machine gives you. And the higher the velocities, the smaller the vessel is. The higher the pulsatility index is, the higher the ICP could potentially be as well. And here are some normal parameters, of the velocities in children and adults, and that's basically what we use at our institution as well. When we say the majority of the time that velocities in the MCAs is above 120, then we start getting concerned, and if they are the peaks above 200 also. This is another example just for you guys to see what the spectrum looks like. Some of the machines come with this spectrum of Doppler in which you can actually your probe in a particular direction, and you can change depths rapidly, and it's going to give you different images, and it's going to allow you to identify the vessels in a better fashion. Same here, but this time through the ocular window, in which you can see the flow of the terminal ICA, and you can change depths as you go. This is one example of a study done from the occipital window, in which, because if you're insonating from the back, blood flow is going away from you, right? And remember I told you it's going to be negative, because the flow is going away from you. And this is just another example of insonation with detection of abnormalities in the basilar artery, showing abnormalities in the flow. So, and this is all nice and dandy, but what can we do here in MRRH to use that technology in order to help you guys, with those two things, detection of cerebral vasospasm in subarachnoid hemorrhage, and also ICP, because we don't have invasive ICP monitoring here. So we'll continue to partner with you, and hopefully in the short future we can find solutions for that. We do have some pupilometers that we will use and leave here that also will give you an indirect measurement of intracranial pressure. Thank you.
Ladies and gentlemen, I would request the two presenters to take the seats over here for the Q&A session. And as they're taking these seats, I'd like to appreciate you all who have worked with them to see that these cases that are going to be handled are handled on. I thank the medical teams around. Thank you so much. In no specific order, would like to thank Dr. Blessing, Professor Kitia, and Dr. Sembatia, who have been behind the scenes of this event. So, ladies and gentlemen, if it doesn't hurt, you could give them a round of applause. Yes, we've heard presentations by the two doctors, and any questions for them? Elvis, you could help me move the microphone. And they'll take 3 questions at a time, and they'll answer them. Thank you. Any questions? Q&A?
Dr. Sava, thank you so much, and Professor Oman for the great and wonderful presentations. Very informative. My question will go to Dr. Sava regarding the brain perfusion, basically in diastole. We noted there that basically the wave goes down, but it doesn't really drop to the end. And that's just because the brain has to keep perfusion. Usually with that wave, how will you be able to correlate together with the vasospasm? For example, if there's going to be ischemia and there's absolutely no perfusion, like in diastole, vis-a-vis like the vessel diameter, can you be able to correlate the size of that wave, be together with, correlate it with the vessel diameter in terms of vasospasms? Then the second one is basically the Spencer curve. This was the Spencer curve there. Vessel diameter versus blood flow. I didn't quite get very well when that curve just tipped off. Maybe if we can show the slide a little bit more, and I could better understand. And with the TCDs, maybe you can, for the purposes of the audience, as you're doing the TCDs, how will you, of course, identify a vessel, an artery vein? We've noted already a positive coming towards you and negative going away from you. But how would you differentiate, a vein and artery? Yeah, thank you.
Thank you so much, Dr. Kava and Professor Omon. Yeah, my question is about, yes, like from your experience, you've used this ultrasound scan and you've seen the success throughout your cases. So are there like programs to kind of link the ultrasound to the current like AI models? I'm coming from the perspective of like machine learning, whereby when you're using ultrasound, right now you have to have the knowledge of identifying like this is an artery, this is MCA, this is SCA. However, are there steps that have been taken to prime such images and coordinate them into machine learning, whereby there's an automated way of identifying these structures? The same way we see like in the MRIs, these days we have like AI codes which have been developed, and they can help really to diagnose some stroke diseases. Yeah, thank you.
Just to take you through, we've just had an AI symposium whereby people have come up with AI solutions to screen for cervical cancer and ophthalmological challenges. So AI is taking the lead when it comes to diagnosis and everything. So there's another question. Okay. 2 here, and then we close off this session.
Thank you very much, Professor Omo. I have just 2 questions. I wanted to ask how big is the machine we use to appreciate the intracranial pressure when someone we are using ultrasound scan, how big is the machine? And also, can we use the bar hole if you want to look inside the cranium? If someone has intracranial pressure, can we use the hole where we have done a bar hole, and then we use that hole to appreciate the intracranial pressure? Thank you.
Thank you. Thank you for this valuable topic. Fidel Tongo from radiology. Mine is a curiosity. I wanted to know whether you can use an ultrasound contrast intraoperatively, much as the brain barrier, the brain-blood barrier is compromised. Thank you.
So we're getting very complex questions, but we can certainly answer them. Do you want to go first? So AI for ultrasound, just like AI in MRI or CT, yes. So AI is being used, but not so much intraoperatively, right? So the people who understand intraoperative ultrasound in neurosurgery the best are neurosurgeons, right? And radiology has not really entered the space, right? And in fact, if you look at neuroradiology is a specialty outside of pediatric radiology, doesn't really know anything about ultrasound imaging. They study CT and MRI. So it's a field that, and there's a lot of neurosurgeons who know very little to nothing about ultrasound even intraoperatively. So it's a limited space. The purpose of this course, we'll talk about some of these advanced things, but what I hope that at least the surgeons and the fellows, right, what you all get out of this today is to, if you have a mango tree, let's say, right, and it's tall, do you reach for the low-hanging fruit first, or do you climb to the top, knocking fruit off on the way because you want to get the one at the very top, right? No, get the low-hanging fruit first, right? When that's empty, then climb. So yeah, I mean, we could talk about all sorts of what's possible with ultrasound and what's coming out from an AI perspective that's helping speed things along. So I'll just give an example. There's something called ultrasound localization microscopy, which allows you to use contrast ultrasound with microbubbles. So this answers the contrast question a little bit. We do use contrast in ultrasound of the brain, similar to cardiac surgery or hepatic surgery, so that can be useful. But you have to have a special machine to be able to view that. And at any rate, ultrasound localization microscopy takes contrast ultrasound and then uses AI algorithms to then actually track microbubbles across the screen over time, so you can actually get a tenfold decrease, so down to the less than 10 micron level, you can see blood vessels. So below the resolution of ultrasound, about half the wavelength of ultrasound, you can now pick up capillary beds. So that needs AI to even be able to function, but it still takes hours. So until we get really good AI algorithms, it's not going to be relevant for the clinical space. So that's just one example, but yes, it's coming. But it won't help us this year, right? This year we need to, our own learning curve, to learn basic B mode, then learn vascular, and very quickly it can be useful in the operating room. ICP measurements I'm going to leave to Dr. Kava, because the most important way to measure ICP, or at least indirectly measure ICP, is with transcranial Doppler and some of the indices with transcranial Doppler. So you don't need the bone off. You use windows of bone through which you can see through with vascular imaging, like the temporal window. But he'll talk about that. Optic nerve sheath diameter can also be a surrogate, so you can use ultrasound to measure the optic nerve sheath diameter. Diameters over 6 millimeters are highly correlative but you have to know how to do that to be safe with the orbit, using ultrasound on the orbit. So contrast we've talked about briefly. That was the third question that I had. So those are microbubbles that you inject intravenously. They cross the lungs and then go arterial. Can be very useful for glioma resections to help distinguish tumor from surrounding brain. But again, you have to have very special machines and probes to be able to use it. And for now, that's kind of on the far side of the learning curve. And more important is learn B mode, be comfortable with B mode for basic things, then get into vascular imaging. And then the vascular imaging can be very useful also at the bedside in the ICU or the HDU to help follow these patients.
Thank you, Dr. Ormond. Starting with Dr. Blessing's questions, yeah, like you mentioned, the diastolic perfusion of the brain is very important, and each particular vessel intracranially is going to have also a different, level of diastolic flow. There are parameters of diastolic flow that depending on what the velocity is, it can be identified, how well the brain is perfusing. Let's put an example, a more dramatic example. Somebody who has suffered from cerebrovascular arrest, brain death, so to speak. Currently in the United States, transcranial Dopplers is one of the few ancillary tests that are being allowed, to confirm brain death. And in those cases, you're going to see an absence of diastolic flow. Absence of diastolic flow in the vessels intracranially. So, and we're using that, we're using angiography, and we're using nuclear medicine. Those are the only three that are currently accepted in the United States. They took away CT angiograms, they took away EEGs, MRIs. Only those three are being used. And that's the most dramatic example of absence of diastolic flow. So you see a spike, and you don't see anything else. Or you can see some reverberant flow. Basically, you see a spike, and then the mirror image in the negative portion. And positive or negative, that basically depends on the direction, the relationship between the probe and the flow. If the flow is coming towards you, you're going to have a positive flow, and the other way around when it's going away from it. And you can color code it, whichever way you want. The more common convention is red for upcoming flow and blue for outgoing flow. As far as the Spencer's curve goes, it's just a physics that was initially published to support the use of TCDs as an indirect surrogate of cerebral blood flow. And basically, like I say, it basically shows that the smaller the diameter of the blood vessel is, the higher the velocity is going to be. But it's going to be a point in which the velocity is going to go zero because there is no more blood going through that blood vessel. So that's basically the mechanics of why we look at that. And each patient is going to have a different Spencer's curve depending on where we at with where they at with their intravascular intracerebral circulation. Hypertensives are going to have a different Spencer curve than people that don't have it. I don't know if that answers all your questions. Okay. And another comment about what Dr. Ormond was mentioning about AI applications for transcranial Dopplers. AI is in the process as well. Andrei Alexandrov in the University of Arizona is actually developed a continuous TCD monitoring with the purpose of machine learning to identify vasospasm in real time. So that's something that hopefully in the next few years will come up. And as far as the ICP goes, there is a parameter in the transcranial Dopplers that is a pulsatility index, and another one that's also called the resistivity index, that basically tells you how much resistance to blood flow you're encountering in the patient's brain. The more resistance that you encounter, it's basically there is, pressure that is fighting against that. So it's not going to tell you, yeah, the ICPs are 20, yeah, the ICPs are 5. No, I'm just going to tell you in the right, proper clinical setting, let's say somebody with a TBI, with a low GCS, if those parameters are high, the pulsatility index, for example, then you have a high suspicion that that patient has increased ICPs, and you should treat it as such.
Thank you so much, our presenters of the morning. Let's give them another round of applause. Ladies and gentlemen, we are coming to the end of this session, but I'd request Dr. Blessing to come. I gave the preamble of this conference and how it came about, but to welcome our guests, as well as welcoming us to the next session. But I request you to ask Professor Kitia to also invite him forward to give us a word as the president of the Neurosurgery Association of Uganda. Thank you. Please come and take the floor in just a few.
It's all right. So, you're welcome, dear participants and the international faculty once again. We're sorry about the small mishap that happened during your travel, and we also apologize to all the attendees. The small, short or last-minute changes to the program, just because of something that happened out of the control. So you're most welcome. Welcome again, the Corridor team led by Professor Omun, Professor Lilhi, Dr. Luis, and Melissa. We always interact almost on a very regular basis with Dr. Luis and Melissa. And we thank you. We're very, very grateful for those teaching sessions. The team here has been able to learn a lot, and I think once you come to the hospital, we shall be able to see some of the changes, especially in the HDU that we've been discussing all along. So the theme of this particular conference was, harnessing technology to improve the safety of neurosurgery. So basically using ultrasound-guided tumor resections, diagnosis, and have some hands-on sessions after the appreciation of the didactic sessions and the use of ultrasound to be able to carry out these diagnostic and treatment modalities. It's like Professor Amon said, it's quite a steep learning curve, so we don't expect ourselves to perform very well immediately, but with subsequent, trainings and conferences that are going to be coming, we hope that we shall be able to improve in the use of ultrasound to do diagnostics and also to resect, brain tumors. With those few words, I would wish to invite Professor Kitia, who is the head of department in neurosurgery at Mbara Regional Referral Hospital and the current sitting president of our society, the Uganda Neurosurgical Society, to just say a word. Professor Kitia, you're welcome.
Thank you very much, Dr. Blessing, and thank you very much for bringing this session is actually. Thank you very much, the visitors from Colorado, for coming to our country. This is the second time you are coming to us, and we hope that you'll be coming many times as we want you to come to educate us. Thank you very much for bringing this new subject of ultrasound, ultrasound. It is definitely a new thing to us, much as it has a long story dating back to 1950, you said? Yes, but everything about neurosurgery is old, because this neurosurgery is among the first operations which were done in the whole world. but every time neurosurgery looks new. The ideas are fresh. Every day we discover new things which help us manage our patients better. A very good example you have given us is ultrasound in monitoring intracranial pressure. We've been struggling to find an invasive way, reliable way of monitoring intracranial pressure. And now we are talking that we are getting near. We haven't got it because they have told us we cannot put a figure. But we are getting near. I can assure you in a few years' time, we shall be putting figures on non-invasive way of detecting intracranial pressure. So I thank you very much for bringing this new thing to us. I will come back to that one later. I also thank you for teaching our people continuously throughout the year in ultrasound, in critical care issues. Our high dependency unit is new, and I can assure you, we went there when you didn't have much knowledge. We were all outside critical care services. But throughout the year, you have given us new impetus, you have given us new knowledge, and now we can manage our confidence with our patients with a bit of confidence, and I can see we can get better, much better than where we started from. I thank the students who have come from Mulago Hospital, from wherever they have come from. Could we show by putting up of our hands those who have come from away from Mbarara, so that we see who have come from Mbarara? See, very good. Some members have come from Mbarara, but this is a new thing, and and not at a very long notice. You have been able to come here to sponsor yourself. You are very much welcome. Then the preparation of this symposium, this lecture, you can see that this year is better than we had last year. This year we are in a better place than we were last year. This year we have got students, we have got other visitors from other stations who have come to us for this course. How has it happened? It's because of that the preparation is getting better. The preparations are getting better. Maybe next time we shall be in a better place than this one, I don't know. And maybe we shall get a bigger number of students, of course, if we give us more time to organize, to inform our stakeholders, to inform those who want to participate, who want to attend, we shall do it better. So I said I would come back to this of ultrasound. Ultrasound is very good. It reminds me of, it rhymes well with services in the low and middle income countries where we don't have the luxury, the sophistication of MRI and CT. It reminds me of the story of conventional myography. I'm an advocate of teaching these skills, these non-invasive skills to our students. Because if you've got a table and you're able to do plain radiographs, then you can do conventional myography at every hospital where these things are. And you can diagnose spinal conditions, therefore. And if you have got the capacity to operate, then you can clearly diffuse the problem. I'm thinking about the Kodikwana syndrome to a general surgeon who had the skills to open to the spine, because we gave them these skills, and he can diagnose it using conventional myography, so he can help the patient. Similarly, ultrasound almost goes to that. If we can get the skills of ultrasound properly, we do a lot of pediatric surgery in this country. Hydrocephalus and spina bifida. Many of our patients come with acute hydrocephalus. where I want to diffuse these conditions quickly, to diagnose them quickly. So I can look at as a general surgeon in the regional hospital who doesn't have the luxury of a CT and MRI. He can use ultrasound to diagnose hydrocephalus and aspirate the hydrocephalus and temporize this condition. So it is a skill, a very important skill which we should pick, which we should master ourselves, especially for us who work in the low and medium income countries. It is going to be very useful for us to monitor patients who have got infections, brain abscesses. Today, we treat abscesses by aspiration. And you can't be sure whether there is no reaccumulation. And once I've created a window on the skull, then you can use ultrasound to monitor the progress of this condition. So it is not only diagnostic, but also monitoring of our patients as we have them on the ward. So I thank you very much for bringing this skill to us. And as a current president of the Society of Neurosurgeons of Uganda, I have already discussed with my board that we include this course in our calendar of activities which take place per year. So, thank you very much. I can see you appreciate this. So we are going to do that so that every year, the dates are known. The dates may not be known, but the time, the season, the time is known. And we can always have our students come here to take the skills and then spread it to the others. So with those few words, I thank you very much. I thank you very much for coming all the way to Mbarara to participate in this very, very important new skill to the clinical, to the neurosurgical services to our patients in this community. Thank you very much.
Thank you so much, Professor Kitia. Ladies and gentlemen, tomorrow we shall be back in the same venue for the morning session. But before then, allow me to also welcome some of our pharmaceuticals. Just in a few, like 5 minutes, we are going to have a snack before we head to the hospital. But before then, ladies and gentlemen, with your permission, allow me to welcome our pharmaceuticals. They usually talk to us on such events to help us, give us insights of their products. And here we have Cacheti, just about 5 minutes, and then we pick a cup of coffee, which can push us to the hospital. Thank you so much. Once again, thank you for attending. Like Professor said, let's be here tomorrow, depending on the cases that we are going to get to listen to. When we get to the hospital, we shall have the demonstrations and all the other events. Thank you for being a great audience. Sorry, Blessing is guiding me on something. Hands-on is here? Oh. Okay, we'll do that here, not in the hospital. The clinical cases will be there. Thank you for the guidance. So, as he's preparing, the pharmaceutical can speak to us, and then we'll get ready for the hands-on. Yeah?
Thank you very much for giving me this opportunity to participate in this conference as a supporter. Thank you, Dr. Blessing, Dr. Kitia, and Dr. Sembatia. So basically, my name is Suchit Pandey. I'm from Cachet Pharmaceutical. This is a company from India. And we have a brand. It's called CogniLife. It is cerebral protein hydrolysate 90 milligram. So from last 1.5 years, our company is promoting this brand, and we are helping with this brand to the patient who are suffering from cognitive impairment. As we see here, it's a cerebral protein, it's a neurodegenerative disorder, or one of the leading cause of death and disability in both developing and developed countries. There are a number of neurotropic drugs used in this disorder. Cerebral protein hydrolysate is the latest one launched in more than 40 countries. So basically, internationally, it is available in injection form, but we are providing in tablet form in 3 African countries. So today, the neurotropic drug cerebral protein is sold in more than 40 countries across Europe, Asia, and Africa. And this drug is sold in India and Kenya from last 5 years. So in African countries, it is available in Uganda, Kenya, and Zambia. We are promoting this brand. So CogniLife, cerebral protein hydrolysate 90 milligram we are giving. This is a multimodal neurotherapeutic therapy. And what is this? This cerebral protein is contains of mixture of 16 amino acids and 8 peptides. So this is basically peptides and acid. The biological peptides of cerebral protein are similar or identical of those produced endogenously. Direct measurement of pharmacokinetics properties has not been successfully preferred, but in that pharmacokinetics data has been established, but it is based on the cerebral protein hydrolysate pharmacodynamics profile. According to the neurotropic activity of cerebral protein hydrolysate can be detected in blood plasma up to 24 hours after single application. So the mode of action of this brand, it works as it regulations and improvement of natural neuronal metabolism, also modulation of the synaptics plasticity, neuronal differentiation and protection against ischemic and neurotoxic lesions. Cerebral protein reducing excitotoxic damage to neurons, also blocking overactivation of calcium-dependent protease, and scavenges free radicals. That's how it treats the cognitive impairment of the patient. So this is also helpful in Alzheimer's disease. There are a 65% success ratio for CogniLife in Alzheimer's disease. In traumatic brain injury and stroke, it has a success ratio of 85%. Cerebral protein hydrolysate segmented proliferation, differentiation, and migration of adult SVZ neuronal progenitor cells results in increased number of neural progenitor cells and neuroblasts. So contribute the neurogenesis. This may be a mechanism for its beneficial effect in acute ischemic stroke and traumatic brain injury. So what happened after traumatic brain injury or ischemic stroke? The person lost his attention, perception, even the memory loss is there. He lost the power of reasoning, planning, and problem solving. So after getting out from the IPD, like from ICU, when they are going for home, in that period, there is a cognitive impairment. For the better improvement of cognitive impairment, we are giving this CogniLife, which is cerebral protein hydrolysate 90 milligram tablets. So cognition and memory improvement is there with the help of CogniLife. And this is the benefits and clinical use. It improves cingulate and cardiovascular injuries, cranial brain dysfunction after brain surgery, amelioration of cerebral function disorder after cranial injuries, treat damage of nervous system due to sudden loss of blood circulation to an area of brain. Also cognitive dysfunction after mild and moderate strokes, cerebrovascular disease, sequela associated with impaired memory and attention deficit disorder. It has supplementary and improvement efficacy towards deficiency of brain functions. So it's called CogniLife. It can be prescribed in traumatic brain injury, stroke, cognitive impairment, Alzheimer's disease, vascular dementia, even in primary dementia also, and Parkinson's disease. So these are the undesirable effects. Obviously, every drug has some side effects, but that is also common, like headache, nausea, vertigo, fever. But as of in 1.5 year experience, I have not got any complaint from our doctors who are already using. So thank you very much for Barara Hospital, Regional Referral Hospital doctors. They have supported me a lot, and we are looking for further support for this brand. We can prescribe 1 tablet OD. Even in severe cases, we can go for 2 tablets, like 1 tablet morning, 1 tablet evening. So thank you very much to allow to present me this brand called CogniLife for the cognitive impairment. Thank you.
Thank you so much. We're going to have now the demonstration. Okay, he's saying he's trying to adjust it so that everyone can see. Yes. As he's organizing, let's pick a cup of tea. And I'm sure you'll listen better. Yes, let's pick a cup of tea as Professor is preparing the presentation. If you don't want the tea, we're taking it in alphabetical order. So let's move. Let's take the cup of tea.
You see I zoomed in where we're at 7.9 centimeters in depth, because this is an infant. You're not going to have to see further than that. And you could even make the depth less or more. And then I turn the gain all the way up. To 100%. At least on this machine, you need the gain pretty high. Then you use a little ultrasound gel so that you don't get air in the way. And then, again, we start with a coronal view So as we look at this, at depth there's the orbital roof. If we look back, now you see there's the two lateral ventricles. So this model has hydrocephalus. So can you appreciate the lateral ventricles there? And the third ventricle, and then you can see those two, the bright areas at the base there, that's the anterior skull base, and the middle fossa floor on the lateral sides. And we come back, and now we see there's the third ventricle, and then we swing back, then you get into the brainstem. So it's not quite as good as a real baby would be in terms of imaging, but you can see in this patient you have hydrocephalus. There's some, you can see the bone, the middle fossa floor depicted here, and it's getting warm enough that it's not happy with me, so it keeps freezing to turn it off. But it's a problem with handhelds is you do have a time limit on utilization, but you can kind of get the idea. And then here, when we come in on the sagittal, a little harder to see on this view, so I think we'll go to Dr. Kava to look at the vascular imaging pretty quickly. So Joseph, you can come up here, take a seat. So you have to control it from my phone. Have a seat. Yes, so the controls from the phone.
All right.
So B mode, and you can do color, power Doppler, or pulse wave.
Let's start with B mode.
You can start with B mode, and then you're live right now. So you can free the button there, not the power button, but the other one that freezes or unfreezes it.
Okay. You have gel?
Where did the gel go? I had a whole bunch of gel.
All right, we're going to demonstrate a quick Doppler. Obviously, this will be the extracranial portion of it. Joseph, thanks for being my model today. So I usually start fanning from the bottom of the neck and start a good image. So you can see right there an actual view of his ICA. And we'll follow it all the way up to the base of the skull. You can also obtain a lateral view. It seems like Joseph is alive, so that's great. How do you control the depth, Ryan? Oh, it's not there. See if I can figure this out. Okay, let's try this. Yeah, I'm going to move the box. So right there. So you can see the pulsatility of the ICA. When I ultrasound the ICA, I always do it very gently so you don't compress the vessel. And you can see also the flow is color coded for red. That means it's towards my probe. Away from my probe. I go down. There. We can get right close to the bifurcation right there. And as we go up, that's only the ICA on your left. Good. Now we'll try power Doppler if it works. You know how many hertz?
I think it's 1 to 5.
1 to 5. Okay. If you can set it, what can we set it in 2 or?
I don't know if it gives you that.
Okay. do I freeze it? It's not live, right? Ready? Okay. So, can you move that to the middle? The box in the middle. There you go. And what is the depth? All right, let's go down to 6 on the depth. Right there. Thank you. So what depends, what we want to try to find here, I mean, it is very difficult with another dedicated probe, but 2 hertz, we should be able to see through his temporal window, and I'm trying to locate a vessel in there. Maybe we can go to 7 centimeters. Okay, right there. 7 centimeters. Hold on. Yeah. But this is basically, you know, the procedure that you use. You locate your temporal window right here. It's right in front of your ear, and you just start. Takes a lot of patience, and it's actually operator dependent. So maybe not a good operator right now, or it's just that technology. Because the probes that we use are usually smaller than this one, but this is essentially what you should look like, or how do you do until you find a blood vessel, and you can have the color Doppler in there and measure the velocities. Yeah, I'm not seeing it. Yeah. Kind of a little bit more anterior, perhaps. I mean, it's penetrating for sure, but maybe if you decrease the gain distally. But we can always try with the machine that you have at the hospital, with maybe easier to handle. Yeah, well, that's the principle, anyways. Okay.
All right, so that's all we can do here. We'll do more demonstrations at the hospital with the hospital machine, which doesn't overheat like the handheld. But are there any questions? Does anyone want to try out the machine on the Phantom? Certainly you can come up and take a few minutes to do that if you'd like. If not, maybe we'll make our way to the hospital.
Thank you so much. Ladies and gentlemen, let's clap for our professor for the presentation. So much, and do you have any questions about the demonstration? Do we have any questions? If not, Professor, yes.
Thank you very much for this demonstration. I'm just wondering whether color of skin can affect the results. Why am I asking this? Because we are running a study on infrascanner and the intracranial injuries. And we have found that actually the color of skin had an influence in the findings. I don't know whether the color of skin can have a problem in this one.
I'm sorry, I missed the question. Oh, no, color of the skin does not matter. Hair can sometimes be a problem, so if you're trying to ultrasound through hair, you do need a little more gel so that you don't have pockets of air between them. Certainly, we haven't found that to be the case with ultrasound, no. And when you're in the operating room and the bone's off and the dura is open, you have superb ultrasound propagation. Works very, very well. You get a lot of attenuation through the skull.
When the skin is injured, it swells.
Certainly, if you're looking through the skin, it creates more attenuation because you have a thicker space between the skin and what you're looking at, and so there's more attenuation. So transcranial Dopplers would be a little harder.
Let's clap for our presenter. And ladies and gentlemen, I invite you for the ORL live demonstrations, and this is going to be in the Neurosurgery Theater on 4th floor, on the top floor. So let's get moving. Those who can give the others a lift, we appreciate, but we have common transport to the hospital side. Thank you. Let's see you here tomorrow. We shall have a recap of today's event, and then kick it off from there. Thank you. Oh, starting time tomorrow is 8:15. So meaning you set off at 8. Oh, it starts at 8. My apologies. We start at 8. Yes.